well. All right, a few more notes on types of ableism and some research about ableism, actually. So ableism may be changing over time, according to some studies that have looked more longitudinally at types of ableism and what it looks like across some more recent generations that we've been studying it. As you might guess, wasn't really a lot of research happening, decades ago about ableism, unfortunately. So our time frame is a little bit more limited with that. But we are seeing that that ableism in general is decreasing in some ways, but it may not be decreasing as much as becoming more covert. So when you try to measure things like people's belief that they'll catch disability, that is less commonly reported. So people may be learning more about disability, and they may be becoming more aware. We know there's been lots of awareness campaigns, so hopefully people are more aware of some things like that, disability not being contagious, but also there's been more awareness that it's not socially acceptable to discriminate on the basis of disability. So researchers do have concerns that people are just less likely to report their ableism, and they're more likely to continue to act it out in their decisions and behaviors. So just maybe more covert. There's also some research that shows that the type of disability may make a difference in your experience of ableism. So in some cases of people with visible disabilities that you can see, they more commonly report people treating them like children, so infantilism, being forced to take or consider or turn away unwanted help, and invasions of privacy, whereas those with less apparent or invisible disabilities report experiences like invalidation of their symptoms or their disability-related experiences, and also accusations of fraud. So the type of disability may make a difference in what type of ableism we experience as well. And just as a note, you'll see my little numbers on these slides. These connect to a references slide at the very end that you'll have access to if you want to see any of the research studies that support these conclusions. So we've talked a bit about ableism. Now let's move into healthcare outcomes for people with disabilities and why this ableism seems to make a difference in a negative way, and how that may exacerbate already negative outcomes for people with disabilities. So our community has largely been unrecognized as a population for public health attention. So when you see, and the last few months has been hopefully a national study of what public health is, and kind of the plans and the policies and the decisions that go along with that. And in many cases, people with disabilities just aren't part of that conversation. Not literally, they're not at the table, and also not part of the plan in terms of how will this uniquely impact people with disabilities. Adults with disabilities are 4 times more likely to report their overall health to be fair or poor. So that is concerning, because that is much worse than the reports of non-disabled adults. And so researchers have begun to untangle that web of the complexities of health with disability to identify preventable inequities. And that's really what we're focusing on here today. So if you were to measure my overall health by the number of bones that I've broken in my life, then I would appear on paper as a pretty unhealthy person. But if you were to untangle that disability-specific aspect of my health from the rest of my health as a person, then you would see that I have some pretty optimal health in other categories of my life. So too often are we kind of putting those two spheres together, where we're considering someone in poor health because of the very aspects of their disability, when we really have to look at it in more layers than that. And then what we're focusing in on are what are these negative health outcomes that are actually caused by being treated in a way that is influenced by ableism, so being treated in an inequitable way. So to do this, we really have to overcome some dismissive arguments that often come from the healthcare system in terms of, and they may not come explicitly, but they're kind of baked into responses. So first of all, it's the idea that differences caused by the condition that led to the disability. So again, untangling that web of, well, does this person have poor outcome, have a poor health outcome because they already had a disability or because they didn't have access to quality care. So it's really the assumption that this was quoted by a provider in one of the studies of healthcare inequities is, well, they are disabled, so of course they are in poor health. So the idea that some people have difficulty untangling those and don't understand that poor health may not have been present before disability and it may not have led to disability. So it's the chicken and the egg is seen as just this ambiguous, which is it, when really if we untangle it, there are answers to that. Also, another challenge is this what's called common sense ableism. So the idea that for some people who don't live with a disability perspective or experience, they assume things to be common sense. So an example that can get me frustrated if I read a news report that will describe something like feeding tubes or respirators, they'll be described almost as if it's obvious that these are just extraordinary, life-saving, drastic efforts that must always result in a lowered quality of life, when, I know I have several friends that live with these as basic realities of their lives, whereas that would be shocking information to the people that both reported those stories and also sometimes the healthcare providers who have these ideas that you cannot live a life of quality if you have a feeding tube. And again, none of what I say is all healthcare providers, but unfortunately, some of these ideas are part of training or part of systems that are built in. So this common sense ableism that makes it seem so obvious to some, when really you're just missing that perspective and lens from really the only group of people that should be able to speak on this are those with that lived experience. So the goal being to parse out these healthcare inequities that are caused by or made worse by ableism or disability bias. So it's quite possible that someone's outcomes could be a result of their primary disability, but are they made worse because of bias or ableism is really the question that we are trying to get at today. So all of what we've talked about so far was really the motivation for several of us to come together and apply for a grant for the Center for Dignity in Healthcare for People with Disabilities. And I liked this cartoon to represent a little bit of what some of you have shared in the chat box as examples of ableism. So the doctor is talking to another doctor and he's pointing behind him to a group of people with disabilities and he's saying, what do you think they want? And the people are saying, to make my own decisions, to be asked information I can access, to be treated with respect. So this center really focuses in on these healthcare inequities, and we are among 8 national partners and stakeholders. And when you download these slides, you'll be able to link to each of our partners that bring rich perspective and their own voices and stories to this. So again, this is the we behind it. We have subcommittees, which each of the topics I'm going to talk about today. We have a center advisory board, and then each of our site partners as well. So it's a large group effort. So this is a 3-year project to establish our center and get us up and running. And our goal is really to identify and reduce life-limiting healthcare inequities for people with intellectual and developmental disabilities. And we're going to do that through improving access to anti-discrimination medical protocols. So that's a lot of very inaccessible words to say that we want medical providers to have more accessible guidelines, because we know those guidelines are kind of the maps to their helping different patients navigate their healthcare. And we want to make sure those maps in themselves don't have like these pitfalls that can lead to bias and ableism. So that's one of the ways that we're hoping to achieve our goal. So we have looked at over 250 different resources to kind of get a landscape feel of what's out there related to policies, guidelines, curriculum. We want to increase access to those anti-discrimination protocols. So we really feel like at this point it's not enough not to be ableist. We really need to proactively be anti-ableist in our healthcare setting, especially because there's such high stakes. We also want to increase access around these issues to people with disabilities and their families as well. So, and healthcare providers and systems. We just think we need to connect the dots more of these different perspectives. And this is what we hope to accomplish with this. So outcomes, we hope that more professionals will have these protocols and resources on hand. We hope that more of them will implement them, which is exciting to see in some of our prenatal work, especially in terms of clinic approaches to prenatal diagnosis. Um, we hope that more medical professionals will demonstrate increased ability to provide equitable care, and that we'll see that expressed as people with disabilities and their families have resources to not only understand these issues, but also advocate around them too. So I know I've already given you quite a bit with ableism, healthcare outcomes for people with disabilities, and a brief intro about our center. So I thought now might be a good time to pause and take what questions you have, and then we'll launch into our second half. So I'm going to open the question box here, and feel free to add those in the Q&A. So I see a first one. Do you see ableism in the area of access to durable medical equipment? I see that area of healthcare extremely overlooked. I definitely do. The example that comes to mind is the technology that allows for the lifting of the chair height. I've heard from numerous people that it's not covered by insurance yet. I've also heard from numerous people how much it helps them in their everyday life, especially in the community, maybe to reach things, or in their home also to reach things. So I think this kind of like tier system of what we cover with insurance and what we don't in durable medical equipment, especially when it's such a personal choice, and these aren't really items of luxury. You know, nobody is trying to get their wheelchair, you know, plated in gold and covered by insurance. So I do see that as an area that ableism creeps in. I know you didn't ask, this doesn't qualify under durable medical equipment, but even adapted driving equipment definitely has a lot of interesting policies around apparently if you have legs, you have to purchase, if you have hand controls and you have legs, you have to purchase a metal plate that goes over your pedals so that you can't use them, because the idea that people are worried that someone might get their foot hung in the pedal. But like in our household, I use the pedals and my husband used the hand controls. So we would have to purchase that plate and then throw it away. So there's this, you know, paternalistic idea built into what is really a customer business relationship. And there's also the idea that everything is medical. So, you know, at no other spot in buying a car do you encounter somebody worrying about like your health in that way. So it's interesting. And then I think the second one might be more of a comment about age as a pre-existing condition, but no other physical issues. Any other questions that you have before we move on? Did I miss
Kara, we have a question from Gwen, and the question is, will the Center for Dignity in Healthcare for People with Disability also focus on brain-based illnesses such as bipolar and schizophrenia, because so much is unique to the community?
Yeah, definitely. Thank you, Gwen. So our center, we are primarily funded by the Administration on Community Living to focus on intellectual and developmental disabilities, but in a lot of the work that we have done so far has been pretty cross disability, and we actually have a specific focus related to mental health and psychiatric disabilities as well. So we'll talk more about that in the second half, but I would say that most of our focus so far has been individuals with disabilities and another mental health diagnosis, not so much just a psychiatric disability, but definitely the work overlaps, and it may more so in the next couple of years.
And then Gwen also had a follow-up question. Do you have someone on your staff that is trained in serious brain-based disorders?
So we have a subcommittee dedicated to the mental health focus, and I'd have to look back. They bring such a wide range of backgrounds and expertise. But if you, Gwen, or anyone listening wants to reach us, we have our email. If you bring that expertise and you'd like to join us, we're always looking for more people to bring aboard. So our staff is relatively small in that we are kind of coalition of multiple USEDs and self-advocacy and family organizations. And so our staffs kind of vary across that. Most of our staff are kind of shared across our projects, if that makes sense. Okay.
I don't see any other questions.
Okay. And some great comments in there too, especially Melanie is bringing up that when asked by professionals how to rate health, it often feels that as a person with a disability, it's expected to rate at a lower rate. And what can we do to help individuals not feel this way? That's a great question, and we'll talk a little bit more in the second half about how providers often underestimate our quality of life as people with disabilities, but um, just there's such a gap between how people rate their quality of health or life and providers, and it can actually go either way, and that gap can be problematic if you're trying to get the right type of care. So that's a great point. And then Avery added some expansion on the brain-based disorders like ataxia, brain injury. So we definitely in our cross-disability work have not excluded any diagnosis that we've said at any point like, well, that type of disability doesn't fit with our work. So in general, we try to widen our net as much as we can. Okay. All right, so we will have another question period at the end. So feel free, if you didn't have any for this at this point, you can jump in later, hopefully. All right, so I'm going to share with you a little bit about our specific work with the Center for Dignity. I mentioned that we've focused in on 4, and really it feels like 5 with our COVID-related work, but 4 areas of focus. And we chose these based on our literature review to apply for the grant that funded this project, but also because, as I mentioned earlier, they kind of are a magnifying glass of healthcare inequities in terms of it kind of comes together either in the potential for harm or in just kind of a general lack of resources to address bias when it pops up. So let's look a little bit deeper into these 4 areas of focus. So prenatal diagnostic testing, organ transplantation. Our third group is aging or end-of-life care. And then 4th would be mental health or suicidality group. So each of these I'll explain has some pretty wide spectrum of issues that would fall into these buckets. And then last is our COVID-19 group that was formed in March and has been quite active since then as well. So our first one is related to prenatal diagnosis of disability. And this group is so active on a number of topics, and rightfully so, because there's just rapidly changing landscape on prenatal genetic testing. It's really exploded in not only a medical sense of innovation, but also in a commercial sense, which whenever the worlds of kind of business and profits intersect with healthcare, it can become challenging for people with disabilities to get equitable outcomes. Also, the legislative climate around this issue has become extremely complex. There are a number of laws that I'm going to show you from the Letter Case Project, and I saw Stephanie in our chat room. So she it leads this effort for us with the Center for Dignity, Stephanie Meredith, and just does and has done incredible work around this area. So I'm going to actually show you the Letter Case Project by sharing my screen, but first just their goal and our goal with this aspect of the Center for Dignity is to provide accurate, up-to-date, balanced, and medically reviewed information about genetic conditions. And at first, you know, when I was considering this, it would seem that that would be the obvious goal for sharing information about a prenatal diagnosis of disability. But we know that many times bias about disability can slip into this process, but also there can be a real just lack of information. So not, you know, many photos of people with certain genetic disabilities at different points in their life. And sometimes those photos too can be very dehumanizing. If you Google my disability, some of the first page of Google images that come up are pretty disturbing. You know, they're the black box over the eyes and, you know, the child without clothes or maybe just a diaper and, you know, on an exam table. So not living in our world, living their life. So you can see this picture of a young girl with Down syndrome. Coloring is just one of the examples of the amazing imagery that the Letter Case Project uses for this. So I'm going to stop sharing this screen to show you the Letter Case Project in action. So this is the resource summary page, and you can see that they have a number of different diagnoses here. And then when you click into one of these, it pulls up a really accessible website for families, again, with these photos that show people just living their life, candid shots. And so they've got different sections here that family members can look over. The information isn't, it's pieced out, so it's not super overwhelming of just, pages and pages of information. It's also backed up with that scientific information, so families can get the original article if they want to. And so you can see that there's just a multiple. It also recognizes that there's more to just a symptom list with a diagnosis. So yes, there's a section on medical issues. There's also a section on families and a section on healthcare and development, a milestones chart, something to support school services. So this is just one example of their resources page that Lettercase offers. Take it to the top. The other piece that I wanted to show you related to our prenatal work and related to Lettercase's work is this really helpful map that they have put together that, and I wanted to show you it in an interactive sense because you can't capture it by just screenshotting it. You can see you can go over each state. So I'm out of Ohio, and then you could click on the state law that relates to prenatal genetic diagnosis. And then in this case, the state fact sheet, which in our state, providers are actually required to hand out a specific fact sheet with a diagnosis. So you can see what your state currently has, and this is Kentucky's. So interesting to me as a policy wonk as well is that our kind of region has kind of adopted a similar approach to this, and there's really exciting and innovative research being done, again, from a policy wonk's perspective of what difference does this make? Does the mandate to require this particular fact sheet, is the timing right for parents? Do they remember receiving the information? So I'm really excited to see the step of looking further into policy from the perspective of impact. And so there's lots of different approaches to this, and there's also political reasons for this that are within the bounds or outside the bounds of our project, but we're trying to understand the full landscape of experiences of prenatal diagnosis for families. So let me stop sharing and go back to my screen. So their subcommittee group is very active, not only looking at implementation of these different strategies to provide more equitable information in clinics, but also taking part in a number of work groups with the different professional alliances and organizations to come to consensus decisions about the best ways to approach this. And again, trying to remove bias and trying to improve the accuracy and balance of information provided to families during this really challenging time for anybody, no matter what you're experiencing during pregnancy. It's a relatively short window of time, but can be stressful for anyone. So our second subcommittee issue of focus is related to organ transplantation, discrimination in organ transplantation. And so I wanted to show you a quick video of a story that was one of several that sparked in the media an interest in others of learning about this issue, and eventually, again, led to some legislative changes, an amazing toolkit that was developed by one of our center partners, the Autistic Self-Advocacy Network. And so you'll have the link to that can show you how you could advocate around this issue in your state, but also really give some important facts that clear up misconceptions about this. But I'm going to show you first this video of the family that shared their story with the media that about this issue.
country, nearly 2,000 children are on the national transplant waiting list. In many of those cases, it's a race against time.
And what we know right now is that some parents have spent months fighting to get their child added to the list. But because there is no state law protecting patients with a disability from being discriminated against.
Caitlin Ross spoke with a Georgia family that is fighting to change all of that. Caitlin?
There's no law against someone with a disability donating their organs after they die. But if someone with a disability needs an organ transplant, that fact alone can get them removed from the list.
What's your sister doing?
Erin Nobles thinks it's strange when people apologize after they find out her daughter, Gracie, has Down syndrome.
So if somebody tells me they're sorry, I would say sorry for what?
Gracie was diagnosed with the disability early in pregnancy, and her mom says in every way, Gracie has been a gift.
She brings me so much joy, and every bit of her that we had to fight for, she has given back to us hand over foot.
It was only after Gracie was diagnosed with a heart defect that they started to worry. When Erin researched what could happen to her daughter, she was alarmed.
If my daughter had needed a heart transplant during all of that time, that there was a possibility she could have been denied based on her disability.
In a report sent to the president this past September, the National Council on Disability found many organ transplant centers have policies that bar or caution against placing someone with a psychiatric, intellectual, or developmental disability on the waiting list. Erin says what makes this worse, many families never know why a patient is deemed ineligible.
So unless they go back and they request the paperwork to see the official reason why the child was denied, a lot of parents don't even know.
A family in North Carolina recently accused a hospital of denying their loved one a heart transplant because of an intellectual disability. They took the fight to federal court and won, with the patient back on the transplant list. But Erin doesn't think they should have to go to court to get added to the list.
For most families, they don't have 2 and 3 years to fight that battle.
The Federal Americans with Disabilities Act protects people from discrimination, but that means families have to fight in federal court. That's why they worked with their representative, Rick Williams, to propose Gracie's Law this legislative session in Georgia. It would allow families to challenge the removal from an organ transplant list in local court and get priority on the docket. Only 12 states in the country offer protection like this, and self-advocate Martha Hayward thinks it's time that changed.
All we want in the world is for our kids and adults is to have that chance to be the person that we are and to show everyone that we matter.
She's fighting in the legislature alongside the Nobles this year to get Gracie's Law passed.
Please fix this. It is time that we get out there, raise the voices as young advocates. Get out. Say the word. It's time.
They'll all be at the State House together January 29th to lobby for Gracie's Law. They're hoping it gets bipartisan support.
Okay, so that was Gracie's family and their advocacy to pass the law in their state. And let me share my screen again. Sorry, I have an inability to talk and share screens apparently. Okay, there we go. So again, this issue has in common with the previous one that there have been a number of laws passed, but I really like the point made that many families facing this challenge, first of all, may not know the reason for denial. So there's not enough transparency around the evaluation process for an organ transplant. And that's one of the areas of focus on this this subcommittee's work, is that some of the misconceptions about disability that are built into the evaluation process are not only unfair, but just blatantly inaccurate. So what I really appreciate about the toolkit linked from Asan is that it clears up with research some of the misconceptions that people with disabilities, the idea that we would be bad candidates for an organ transplant because maybe someone with an intellectual disability would not follow up with appointments or would not take medication as prescribed. And in reality, research has shown that individuals with developmental and intellectual disabilities are actually more compliant with medical follow-up after a transplant, and there may be reasons for that, like they may already have a support system in place. They may already have someone that will help them get to appointments or remind them to take medication if that's needed or wanted. So there's lots of reasons behind it, but the kind of primary point is that people are excluded from transplant lists on a completely inaccurate idea held by our healthcare system. So first of all, some of the work has been to clear up those inaccurate ideas, and also to kind of go back to square one to look at what goes into an evaluation for an organ transplant. So organs are an interesting facet of our healthcare system because there's not, it's a supply and demand issue. So there's a greater demand than there is supply. So there's this decision-making process that can be fairly subjective in the middle of a person being recommended for a transplant, evaluated, and then put on the list. So there was a great point brought up in that video of the lack of transparency when people are denied. So many times families don't even have the opportunity to clear up or to give more information about an individual. But the other important point of that video was the different timelines. So, and that's really where I have questions again about what impact, if at all, will some of these laws make, is that while in Ohio we have a law in place that prohibits the discrimination in organ transplantation on the basis of disability, one of the concerns that we have as state advocates is that providers could simply list a different reason for exclusion or denial of putting someone on an organ transplant list. So the policy may not get us to the end goal that we hope, and so we need to, as advocates, not stop after a certain law is passed, because its implementation and what it looks like in the real world is actually what matters the most. And that is a huge issue with this particular focus area, because families could take a hospital system to court to fight, and on the side of the law they may be right, but their loved one doesn't have years to figure out this battle in the courtroom. So the legal timeline and the health timeline just don't line up in a way that makes policy the only solution to this issue. So this group is also working with a number of different professional entities to understand more about that evaluation process, and also figure out, even before you get on or off a transplant list, there's a whole nother series of things that happen about when and if at all providers recommend people to even start thinking about a transplant. So there's some interesting work done with the social work field, actually, that evaluates patients based on kind of whether social workers feel that patients would be a good fit for transplant. And there's research around kind of how early a social worker would bring up the topic of transplantation to a person. And the challenge with that is that we can look at inequities in terms of what that provider might think they know about that person's life, about their compliance, about that person's quality of life. And all of that, unfortunately, when you're using a very subjective way of when to kind of introduce the idea of transplantation, all of that can be influenced by ableism. So while it's exciting and we need to think of innovative ways to kind of involve interdisciplinary approaches to organ transplantation, we need to make sure that all those discussions and new transformative approaches consider that the equity lens, and make sure that we are treating all of our patients with dignity and assuming that quality of life is a reality for all patients.